So a little bit about Southeast Orthopedic Specialists. Some of you may be aware that we are a multidisciplinary group of different orthopedic surgeons focusing in all different aspects of orthopedic care, and everything from adult reconstruction to sports medicine to hand and foot and ankle surgery to spine surgery. We have physiatry and pain management and chiropractic and podiatry. And so we are a team that works well together, and you know, our goal is to provide the best possible patient care. And you know, we feel that your best care is in the hands of doctors who specialize in a particular area and are fellowship trained. Our group is becoming well established in the North Florida area, and these are a picture of our current offices, and we have added a new office in the Riverside area to serve the needs of the community. We also have offices up on the north side, Fleming Island, south side, and the beaches. A little bit about me. I've completed my medical degree at Queen's University in Kingston, Canada. I have completed my orthopedic surgery residency at the University of Calgary. I then realized I loved adult reconstruction, and I went into a fellowship at Mount Sinai Hospital in Toronto, Ontario, where I looked at complex hip and knee replacements, and also in hip surgery and in hip preservation at the Sharp Memorial Hospital in San Diego. I am a board certified fellow of the Royal College of Physicians and Surgeons of Canada and board eligible at the ABOS. And I have my professional affiliations, as you can see below. During this talk, I am going to talk about different types of hip and knee replacements, and I wanted to disclose that I have been involved in a research project with Stryker Orthopedics, who is involved with the Mako technology I discussed. The first part of my talk here, I'd like to talk to you about advances in hip surgery. And really the point of this is I want to talk about some of the advances that we see in the short-term post-operative period that are relatively new, and how we can still preserve the long-term outcomes that have been so excellent with hip replacements. This is a picture of the hip, and what I want you to see here is that the hip is a ball and socket joint, but look at the movement it has. And if you look at beside the ball, we call the femoral neck, we see that that is recessed. That allows the hip to come into an abducted position, into a flex position that we see here, to extend the hip during walking, to internally rotate the hip as you see here, and to externally rotate the hip. So hip problems can be kind of difficult for doctors to identify sometimes, because if you look at where patients describe their pain, this is a picture from a study where we looked at all the patients who had pain that was caused by the hip, and look at all the areas that they reported. You see that in the groin area, most people do report pain, but sometimes people report pain in the thigh and even in the buttock and at the side of the hip. These can be confused, and sometimes it can be a number of years before we see the patients finally get treated for their hip problems. So something to keep in mind. I wanted to talk to you particularly about osteoarthritis, and now many different problems can cause hip pain, but as the wear and tear in the joint progresses, arthritis can develop, and osteoarthritis is the most common type of arthritis. Sometimes people get confused about what exactly arthritis is. If you look at the picture at the bottom right, it has a zoomed in view of the femoral head. You can see that the shiny white cartilage that I showed you on the video can become worn away, and the red areas represent bone spurs, and those are the common signs that we see those are the common findings we see with osteoarthritis of the hip. unfortunately, hip arthritis is increasing and it affects up to 31 million Americans. And we have a generally good understanding of hip arthritis, but the predisposing factors seem to involve age, with wear and tear phenomenon, with increased weight and lack of exercise. Now, if you look at what causes hip osteoarthritis, think of that video I showed you at the beginning where I showed that, really a perfect hip that could move throughout range of motion and that there was no impingement. Well, it turns out that patients can have a predisposition towards hip arthritis if that femoral neck area is not recessed enough, or if the socket itself overcovers the hip, and that is on the left side of the image here. And we call all of these problems where there's impingement of the femoral neck on the socket, we call that hip impingement. So if you think of it, the hip can have too much coverage, which is on the left. The other problem that we see a lot of is called hip dysplasia. And if you look at the image on the right, and you look at the socket part or acetabulum, you'll see that that's very shallow and very vertically oriented. What happens there is we get too much force on that ball in a narrow area, and too many, in layman's terms, too many pounds per square inch. Well, both of these problems can converge, and we see on the bottom that osteoarthritis can develop, and often the predisposing event to that is the cartilage around the hip called the labrum can become torn, and both of those lead to the changes of osteoarthritis. So what can we do about this osteoarthritis pain when you come in? First of all, there's education. We need to be aware that certain positions, such as sitting in low chairs or low squats, can cause those bone spurs to become painful. So we need to avoid those. However, physical therapy in which we strengthen the hip muscles can be very advantageous and decrease pain and improve function. One of the things that's hard, of course, is weight reduction, but through diet and through modified exercise, that can really help. And the less weight that the joint sees, the less pain that the patient can have. Anti-inflammatory medicines may be very useful, provided you do not have any kidney problems or stomach problems or other risk factors with anti-inflammatories. Those include Advil and Motrin, Aleve. There are many different kinds. They can be helpful for arthritic pain as long as patient is a candidate. And at the bottom are some of the other treatments that can be done for hip pain. Cortisone is FDA approved, and this is essentially a purification of the body's anti-inflammatory hormones, which can decrease pain and swelling and help with function. There are other treatments for the hip, but they are not FDA approved. However, we do offer them. They are including hyaluronic acid, which is really an attempt to restore the normal joint fluid, which has a cushioning and pain relieving role. And there is regenerative therapy, which can involve platelet-rich plasma and stem cell therapy. I wanted to talk particularly about hip replacements. And this is really why I entered into this area of orthopedics. I love hip and knee replacements, but especially if there's one operation that works great, it is hip replacements. And some people actually call it the operation of the 20th century. Many of these are done every year, up to 1 million of these operations. And over the years, of course, we've learned what works and what doesn't work. We are unfortunately seeing an increased number of younger patients requiring these procedures than in past. But generally, the patient satisfaction is excellent with hip replacements. The hip joint itself, if you think of it, is easily replicated, given that it's a ball and socket joint, and therefore the function can be excellent, and that these replacements are generally well designed and last, we expect, 25 years for 80% of patients. This is a little bit about really the pioneers of hip replacement. At the top left is Sir John Charnley, who is from England, and Maurice Müller from Germany. And really in the early 1970s, the modern hip replacement was born. And since that time, of course, there's been evolution as we've learned more and more. There's been changes in the actual implants that we put in. There's been improvement in decreasing the wear through different bearing surfaces. There has been an improvement in the way the surgery is done so that the recovery can be much faster. We are seeing less blood loss now, and we're making use of the current technologies with robotics and computer-assisted technologies that can help us improve the accuracy of this operation. Now, this is really an important picture, and what I want you to see here is that if we look at the hip from the side, we see this, the first thing we see is this gleaming long white tendon. You'll see that it extends from the hip area and all the way down the knee. And over the years, I think most surgeons would agree that we've learned that that is very important to preserve the function. You can see that the muscles of the hip from the back, the gluteus medius and maximus attached to it, and even from the front, we call the muscle the tensor fascia lata. And what does it do? Well, this is an example. You can see on the left side a schematic of the forces on that IT band or iliotibial band, and that they pass over the side or trochanter of the hip area. And it's almost like this picture of the tent that we see at the right, where we have these pulleys supporting the structure of the tent and draping themselves over the center part. Although if you look at it a little further, on the left side, you'll see that there are a number of different muscles attaching to this tendon from the front and the back. And so really, maybe it's a little bit more like a circus tent that we see on the right side here. What happens if that's cut? We see the picture on the right here, that the function of that tendon is permanently altered, and we see that the function that it gave before in supporting that tent, or in other words, the hip and knee, becomes compromised, and that pain can result and decrease function. And this is a study where they looked at, in cadavers, they looked at the muscles and their attachment to the IT band. And they also, on patients, they looked at the muscle function through what we call EMG study. What they found is that the main way that we keep balanced as we walk and the main way we level our pelvis is through this IT band. And I should tell you that's very important for posture and for the entire way in which we walk, so that this is a very important tendon. Now, traditionally, hip replacements were done through a posterior approach, meaning that that tendon is cut on the way in. And that, at the time when the hip replacement was becoming pioneered, this was an easy way to access the hip and to perform that operation. But there are downsides to that. In the short term, we see that patients have increased pain. We see that there is increased blood loss, and that we need to protect the hip, sometimes with a foam pillow after surgery like you see on the right here. In the long term, patients may have problems with their gait. Sometimes the surgeon has to lengthen the leg to improve the stability. And that in the past, surgeons have had to use special implants to keep the hip stable after they cut that tendon. So I wanted to talk to you about a different way of doing hip surgery, which is really the newest way of doing surgery on the hip. And that's called the direct superior approach. And the main thing I want you to take away from this is that white IT band tendon is not cut during this operation. And this is a video here. If you look to the right side, you can see that the muscle at the side of the hip is opened up. And what I want you to take away from this is that muscles are moved out of the way, but at no point here do we need to cut any tendons, and that IT band tendon is below that area and never gets damaged during the procedure. And that is the key. Here you'll see we place retractors around the tendons, and we're able to open the hip capsule in this way, as you'll see here. And then the remainder of the operation can be done with no trauma to the tendons of the hip joint. And so the advantages of the operation for patients are really that the recovery in the hospital can be much faster, and patients can go home the same day from surgery. They can walk the same day, and very quickly move from a walker to a cane and then to nothing. And that is a major improvement in comparison with previous surgical methods. The hip is inherently more stable, and patients are able to perform the activities they want to do, sitting in chairs and so on, without the same restrictions which are often required for a posterior approach. And this is a video here of a patient at 2 weeks post-operatively, and you can see the patient can sit up from a chair without problems, and has had an excellent early recovery. And I apologize that was sideways there. And those are really the key advantages in the short term from this procedure. Now, I wanted to talk to you particularly, sorry, I've gone ahead a little bit. Not sure if we can, not cooperating with me here. The key to doing hip replacement is that when we do these surgical approaches, we want to make sure that we place the parts in the correct position such that patients will do well and not have risks of dislocation or early wear and so on. This is an area where the current technologies that we have, including robotic technology and computer-assisted technology, can really help us to place the parts of the hip replacement. And you can see on the left screen, this is an example of the robotic technology with the Mako device. First of all, we start with a CT scan, and we're able to plan the operation and to minimize any limb lengthening and to restore the natural tension on the muscle. And you'll see that at the left. That's a plan before the surgery. That's not the final x-ray, that's actually the plan. In the middle part of the x-ray, the advantage is that we're able to tell in real time how long the legs are, such that we can avoid, again, any over lengthening of the leg. And on the right side, you'll see that the surgeon controls the entire operation. However, the robot allows the surgeon to place the equipment for the operation wherever the surgeon wants to. I'm going to show you a video here. Hopefully this will. That's right. Okay. Sorry, we're having a little bit of difficulty. One moment here. Sorry about that. So what we've, I'm just going to skip ahead here. One moment. Just kind of, is it still? Okay. We've got some videos to show you here, and they just have taken a moment to show up. What I wanted to show you is the way that the Mako robot can be used during the surgery. You will see that we start with a CT scan for the patient, and in that the team of what we call MPSs who work with the surgeons closely, we're able to create a model of the patient's anatomy. So this is the CT scan part of it, where the patient's anatomy is captured, and then this shows us a screen in the planning stage, and we're able here to place those components of the socket part of the hip replacement. If you look at the right, you'll see the parameters we have there. And prior to the surgery, we can sit down and customize the hip for each individual patient. During surgery, we show the robotic technology, the anatomy, and then over time, as we capture more and more points, the accuracy improves to where we get within a millimeter of accuracy doing this operation. These are literally what we see during surgery. On the right there, you'll see the CAT scan that we see. Through progressive points, we're able to know the components accurately. Here is where we prepare the acetabulum using the robotic arm in that position that we have chosen, and we were able to safely place that to protect the patient and to avoid any positioning issues there. And then we're able to put the parts in. This is the actual titanium shell that goes in. Again, the robotic technology can help with the accuracy of that. You see it being seated there. And then we can place the final components, the liner and the head in situ and the femoral stem. So that really is how robotics can help us with the placement. And this is an example of a patient of mine. On the left side, I had performed a hip replacement several years before, and on the middle part, the patient underwent the CAT scan. And on the right side, you'll see on the far right side of the screen was the new hip that we placed. Now, it may be hard to tell what the advantage was, but the angle of the parts had improved, and that with the improved surgical technique, the patient stayed 1 day less in hospital and had a rapid recovery. And that really is the advantage of this technology. Now, I wanted to talk about some other advances in hip replacements. You may be aware that some parts for hip replacements just haven't had a great track record. On the left side, in the 2000s, there was a lot of interest in using large metal heads, which you'll see there. The reason was that the wear on the metal heads in the laboratory seemed to look good and have a low chance of causing issues, and the stability was improved. However, we found over time that the metal caused problems with inflammatory reactions, and we no longer use those parts. We now know that the best bearing surface is on the right here. We see the pink of the ceramic ball on the polyethylene, and we know now that that is an excellent bearing and has very low wear and lasts the longest. And the way that we come by this information is through large studies that we call joint registries. And you'll see, for example, in this graph, if you look at the baby blue colored line on the bottom, that is the ceramic on poly, which is what I just showed you. And you'll see that that has the lowest revision of any of the combinations, and that orange line is the metal on metal. And through keeping, and you'll see the numbers, you'll see at the bottom that we're, when we keep massive registers of these joint replacements, in the 30 and 40,000 range, we can tell these differences, and that has really improved patient safety and longevity. And a couple other things, we now know that as orthopedic surgeons, we need to be more than just surgeons, we need to be doctors. We need to give our patients the best possible chance to recover. We need to improve any issues that can play a role in causing problems. So we look for making sure the patient is well nourished, that the medical conditions can be improved, and we try to come up with a clear plan for physical therapy and for a plan to recover at home. With anesthesia, we found that spinal anesthesia, when it is possible, can improve patient outcomes with less nausea, less blood clots, less pain, and can have advantages in that fashion. We now have much improved ability to avoid blood transfusions. We use tranexamic acid, which has dramatically improved blood loss. And finally, in terms of pain management, we avoid narcotic medicine as much as possible and only use it for a short period of time, and we try to attack pain in many different ways. And so in my opinion, the future of total hip replacement is in sparing the IT band, in utilizing the new technologies to improve the long-term outcomes, and to improve the cost effectiveness by giving patients the early ability to recover and avoid lengthy hospital stays. Now I wanted to talk about the second part of my talk. I wanted to talk about knee surgery and talking again about some of the short-term benefits and long-term outcomes and some of the new developments we're seeing in this area. If we look at the knee is a different joint. It's not a simple joint like the hip. It's not a ball and socket. Here, if we look at the medial or inside part of the knee, we'll see that femur actually rotates and slides on the medial side. Whereas if we look at the lateral side here, the lateral side moves a great deal more, and that the ligaments at the side of the knee are very different. Here, the lateral ligament is cord-like and doesn't move very much, whereas on the medial collateral ligament on the other side has a very different function. And these things are important to keep in mind, because when we're trying to recreate this motion in the knee, it becomes challenging, and that, as I'll allude to later, we need to consider this for each patient, that we want to recreate what is normal to them. Here is a view of the patella or kneecap moving in a groove. The main muscles that attach to that, the quadriceps tendon and patellar tendon, like to be at a certain length and like to be centered on the femur. And so these are the challenges in knee replacement, is recreating the normal tension on the ligaments and the normal kinematics, or in layman's terms, the normal movement of the knee joint. Now, how does knee osteoarthritis happen? Well, there are theories about knee osteoarthritis, and there are associations. We know that, with trauma to the knee, that the meniscus, if it becomes damaged, that can be a risk factor. Again, we see that advanced age is a risk factor. For some reason, females tend to be more at risk of knee osteoarthritis than men. And we see that obesity can be very strongly correlated with knee arthritis, both from a mechanical standpoint and even with the increased inflammation that we see with obesity. If we look at an arthritic knee, here on the left side, you'll see two knees. The one on the left is a normal knee. You'll see that the articular cartilage, that shiny white area, looks normal, and that the inside and lateral side, the meniscus, are intact, and that there is space between that joint. On the adjacent image, we see that there are bone spurs that have formed just like we saw on the hip, and we see that the cartilage is worn down. And we can look at this on an x-ray. If you look on the image on the right, again, we see a normal knee on the left-hand side of that image with normal joint space, and then we see an arthritic joint where the joint space is worn out and the knee is shifted over, and we can see bone spurs forming there as well. And it's not just the cartilage. We now know that the bone underneath the joint does change in an arthritic knee, just like a shocks in your car, that spongy bone plays a role in protecting that cartilage, and that fundamentally changes in addition to the articular cartilage. Now, what do we do when we have knee arthritis? First of all, one of the best things we can do is to try and keep our body healthy, doing low impact aerobic exercise, whether it's swimming or elliptical or yoga or stationary bike. These things help a great deal in keeping our muscles strong, in providing pain relief through endorphins, and in giving us better strength in our joints. Weight loss is one of the best things, again, that we can do for an arthritic joint. By decreasing that load through that worn cartilage, we can decrease pain and improve function. Again, medications can be very helpful if the patient is a candidate. Anti-inflammatories and Tylenol can be helpful. Injections in the knee, which are FDA approved, include cortisone and visco supplements, which I mentioned before. And then some of the exciting new treatments are with regenerative therapy, and we're finding out more and more about that. Some patients do benefit with an unloading brace to take the pressure off the arthritis, particularly if it is on one side more than the other. This is an example of a brace. If you look at this image here, the patient has arthritis on the inside part of the knee. With that hinge in the brace, we can take the pressure off that joint to really decrease pain and allow the patient to improve function. Now, when we talk about our role as doctors in treating arthritic pain, what we want to do is identify what precise type of arthritis there is, and we want to treat the patient in the least invasive method possible, and only move to more invasive treatments if the lesser invasive treatments have failed. But with that, I wanted to talk to you a little bit about treatment, surgical treatment for osteoarthritis. You'll see on the top image, you'll see a knee in different states. On the far left side, you'll see a very localized area of arthritis on the knee. And then we move on to the right, and we see that knee arthritis can affect one part of the knee in particular in some cases. And then as we move to the right, we see that knee arthritis can really spread through the joint. Well, when we look at the surgical treatment for each of those problems, it is different. And that when the arthritis is very early, in some cases there is a role for doing knee arthroscopy, provided the arthritis is very localized. When the arthritis is in one side of the knee in particular, then partial replacements, which you'll see at the bottom, and predominantly medial partial replacements have shown an excellent track record. When we look at the image at top right, where the arthritis is spread through the joint, then predominantly a total knee replacement becomes the treatment of choice. This is an example of an arthroscopy for a patient with some arthritis. We can see predominantly the middle image, we see a loose piece of cartilage that caused that patient's knee to catch and lock up. And by removing this, the patient's function can improve. Now, knee arthroscopy is not a cure for osteoarthritis, but it can play a role in improving symptoms. In some cases, one of the new advances we have is to remember that the bone underneath that joint plays a role in the progression of the arthritis and the pain. And a procedure called subchondroplasty can be performed, where we target those weak areas of bone and that we strengthen them by putting some bone graft in that area. And that can be done at the time of arthroscopy in the appropriate patient, depending on the MRI findings. Now, I wanted to talk to you particularly about what we call varus knees, or medial knee osteoarthritis. And you'll see, for example, a cowboy here on the left side, that the knees can be bow-legged. And over time, that can lead to arthritis on the inside part of the knees. And you see a patient here on the right side. And this is really a special type of arthritis because it's very contained, and it really depends on the ligaments of the knee to be intact. And you can see that on the left side here, with the patient putting their weight on it, that the knee can close. But when we try to correct the knee by putting a little bit of force on the opposite side, that really it is intact. And you'll see that on the image at right. And these are special x-rays called stress views that we need to do in the clinic. And this is not this is from a cadaver. This is not the way we do this type of surgery. We use a minimally invasive incision. But what you'll see here is that the knee has very severe wear on one side, on the inside part, and then on the opposite side it's completely preserved. And that those are really the patients that are excellent candidates for partial replacement. You can see the ligament in the middle of the knee called the ACL is intact and must be intact. And here's an example of a patient of mine. You can see on the x-ray on the left side that there's severe narrowing on the inside part of the knee. That patient did very well with this partial replacement that you'll see on the right side, and they were able to return to their activities. And if you look at this, why would we do a partial knee replacement? Well, on the left side, when you compare partial replacements with total knees, we see that patients are actually more satisfied. And it's probably the less surgery the patient has, and that less of an insult to the knee and a more normal feel. And that's really the key advantage. The recovery can be faster than a total replacement. And that overall, patients are able to kneel on the knee a little bit easier than total replacement. Now, there are downsides. In my practice, approximately 20% of patients are candidates, so it isn't appropriate for all. The longevity is similar in that they tend to last close to as long as total knee replacements. But it is slightly less at the 20-year mark, and in the range of 3 or 4%, so it's not huge. These operations are technically demanding, though. So I wanted to talk to you a little bit about total knee replacements. Maybe some of you have a friend who has had one or even had one yourself. And I wanted to talk to you a little bit about the history. Again, if you look at on the left side, we have John Insall and we have Dr. Ranawat. And these are some of the pioneers of knee replacements. And they really helped to make knee replacement a successful operation in the 1970s and 80s. And that is a picture beside them of one of the first knee replacements. Now, over time, knee replacement design has changed a little bit, but generally, as I'll talk to you about, we're still using the same type of concepts. But nevertheless, knee replacements have improved in their design, in customizing the alignment to the patient, in improving the pain by avoiding trauma to the ligaments, in having longer lasting fixation with the advances in 3D printing and metallurgy, and also in using robotics. Now, this is a concept of how surgeons are taught traditionally to perform knee replacement. If you look at that image, there's really two rectangles there. There's a flexion gap and an extension gap, and that we were taught really to make everybody the same, to align the knee in the same way, and to have those two rectangles match. And if you can do that, then generally a successful knee replacement can be done. However, there are some drawbacks of that. You know, in between those two positions, sometimes patients have some instability, what we call mid-flexion instability, which bothers them going downstairs and so on. But generally, it's been a good technique. And I wanted to show you that this was a patient of mine. If you look at the left side of the screen, you see a very worn out joint, and the patient is carrying some extra weight. You see complete wear and tear. Using these principles I've just shown you about, I did reconstruct this knee. This was about 5 years ago. You can tell that the patient has improved and has lost some some weight, and that the knees are now straight, and that overall the patient did very well, and those crutches there on the left side, the patient was able to get rid of those forever. So if we follow these principles, definitely they help when the changes are bad with knee replacement. But the knock on knee replacement is that when you read is anywhere from 10 to 20% of patients after knee replacement still have some pain, and they do not describe the knee as normal. And we as surgeons are left scratching our head. Is this a problem that the parts aren't designed well? Is it the way that the parts were put in? Is it what the patient was expecting before? Or is it maybe our own ideas? Maybe the original concept of how we do the operation wasn't correct. How can we, at the end of it, how can we push those numbers closer to 100%? And so really it becomes, we go back to the original concept of a successful knee replacement was we had begun with a way to make the knee replacements last by doing them in a particular way. However, we're all different, and everyone has a different knee anatomy, everyone has a different ligament tension, and so on and so forth. And so the concept that one size fits all really just doesn't hold. And without getting too complicated with you here, if we look here, this is just a change in concept of how we do knee replacements. If you look at the picture on the left side, we see a man who is born with slightly bow-legged or varus knees, and that is the way that their body was formed and their ligaments were made, and that is the way that is natural. And if you look at the image beside, the blue line represents the line of force. Now, the problem with that is that we know that knee replacements cannot stay position and cannot hold with that abnormal line of force. There's too much bending force. But yet that is how the patient's ligaments feel the best. And the answer really is that we must try to move the patient closer to where they were before within the constraints. And that is what we call kinematic alignment, where we strive to recreate as much as possible the normal alignment of the limb with the knee replacement. And you'll see that on this image here we've, instead of putting that blue line in the center of the knee as we were always taught to, we move it a little bit to the inside where the patient would like it, but not so far that the joint replacement will fail. And the reason for that is that patients report improved satisfaction, and that generally that is becoming the way that we are doing knee replacements nowadays. And what is the role of robotic technology? Again, these changes are difficult during surgery. It's difficult to assess the optimum alignment of the patient's knee and also the optimal tension on the ligaments. Well, robotics is improving that. And you'll see, for example, this is a picture I see during surgery sometimes where I'm able to tell the distances in the knee in different areas, and I'm able to tell the correct tension and even the alignment of the knees. And this is an example. If you look on the far left side, there's a picture of me using the robotic arm during a training session and the knee replacement that we performed. You'll see that this is a example that the technology provides feedback to the robotic sensors, and that the tool of the robotic arm is used by me during surgery to perform that procedure. And I wanted to move on to the way that the actual implants are changing. It's hard to tell here, but the image on the left side is a traditional knee replacement. We have a white plastic box in the middle to provide the stability from medial to lateral. But if we look at the image on the right side, we see a circle, and that really represents that normal pivoting point on the inside or medial part of the joint. They are now making the designs to recreate this normal motion. We're also seeing improvement in the materials with the plastic having less wear in many different ways so that the knee replacement lasts longer. One other point I wanted to make here, we strive to place knee replacements that will last the rest of the patient's life, and that the goal is to provide a biologic fixation. In other words, for the bone to grow directly onto the implant and to stay that way for life. These on the left side, we can see some engineering of tantalum at the top and titanium. You can see that the engineering they've done is to try to recreate the bone that is on the right side. And as they've gotten closer to that, they see improved bone ingrowth and improved properties in terms of the elasticity of that material, such that bone can grow directly onto that and provide a lasting fixation for the knee replacement. These are some examples of the knee replacements we do. If you look at the top left, you'll see the gritty undersurface, which is really what you were looking at a closer level. And on the right side, you'll see that that is an example of a knee replacement that's grown directly to bone. On the bottom is the traditional bone cement. You'll see that the parts are more smooth and polished, and that you can see the bone cement at the bottom right. And still, at this point, I think we're at a point where metal or press fit knee replacements are beginning to become more widely used. However, the bottom, the cemented, would be the standard treatment. A couple last thoughts before we get to some questions. The way to get early excellent outcomes from knee replacements is to avoid the trauma to the knee. So really avoiding any constrictive tourniquets during surgery to keep that healthy quadricep thigh muscle intact, to avoid blood loss and to lower blood clots can all be done by avoiding tourniquets. And I've done this for the last several years, and it's made a huge difference. This is the study that made me change my mind about 5 years ago and begin to do this. These are from an MRI scan of a patient who's had a knee replacement. And you will see that on the left side, if we look at a patient before surgery, look at the center part, the muscle, where it says TKA, you'll see it's nice and large. However, if you look after 2 weeks after they've had this tourniquet, look at how that has been shrunken down in comparison with the opposite side. So really the tourniquet is to be avoided, and we can still do excellent surgery without it. So I wanted to conclude my talk here by saying that knee osteoarthritis is many things, and that at each stage of the disease, the treatment can be a little bit different depending on what we find. The new technologies that we have now have definitely improved patient outcomes and will likely provide long-term lasting knee replacements for patients that need them. And we need to avoid the idea of a one-size-fits-all approach.